Go ahead, please, Dr. Saad.
Hello, everyone. I'm really honored to be an organizer and moderator for today's meeting, and I'm really happy to see all of you here. Just to remind you, we started this scientific activity long time ago, more than 1 year, as a part of our partnership with University of Kentucky under the scholarship sistership program of the International Society of Nephrology. We started the first scientific meeting on 28 Jan 2022 under the title of CKD-MD. And 2 months later, we have the second meeting under the title of GN Part 1. And 2 months later, we have the third meeting under the title of GN Part 2. And the last meeting we done was in 29 July 2022 under the title of Hemodialysis Part 1. And after that, we have taken a short rest because of the preparation for the 12th International Mansoura Nephrology and Dialysis Unit Conference that was held in Port Said in September 2022. And actually, we have a very strong and powerful contribution from our partners from the Kentucky University, namely my colleague, Professor Amr Husseini, who is dividing himself between the state and Egypt. And also, I would like to thank Professor Peter Sawaya and Professor Michael Renkler for their contribution. And I wish to see the same contribution in the coming Mansoura Nephrology and Dialysis Unit International Conference that will be held this September 2023 in Port Said as well. I would like just to turn your attention to the meeting agenda today. Actually, we have a very brilliant speakers, and we have a well-selected presentation and title of presentation, and I'm really very excited to hear from them. We'll start, as usual, by a quiz that will be presented by Dr. Adam Dosagi, which is a fellow from of nephrology from UK. He will present his quiz and will give you time just to answer, and please don't answer here in the chat room. Please write your answer in a paper, and we'll see and compare your answers with the correct answers that will be by Adam at the end of the meeting. After that, we'll have the first lecture. The title of the lecture will be about a common problem we are facing in hemodialysis, which is the hypercoagulability and the use of anticoagulant in hemodialysis patient. It will be presented by Professor Tyler Smith, which is an associate professor of nephrology from the University of Kentucky. We will jump to the case presentation, and the case presentation is related to the title of the previous presentation, I mean lecture 1. It will be presented by Dr. Amandeep Singh, which is a fellow of nephrology from our partner from University of Kentucky as well. The next or the second presentation will be done by Dr. Mona Tawfiq, Assistant Professor of Nephrology from the Mansoura side, from Mansoura University, Mansoura School of Medicine, and she will present a very interesting topic as well, one of our daily practice, which is about the nutrition, how to assess nutrition and how to assess malnutrition in our hemodialysis patients. This will be followed by a second case, which is related as well to the second presentation, the malnutrition, a case of malnutrition in hemodialysis patient, will be presented by Dr. Atabak Bersa, which is a fellow of nephrology from the UK side. I would like, please, if you all can welcome the co-moderators of this meeting. From the UK, we have Professor Peter Sawaya, which is the chief of nephrology and bone metabolism division from the UK. Professor George Davis, which is adjunct professor of pharmacy from the UK as well. And from the Egyptian side, I would like to welcome Professor Hisham Saib, which is a professor of nephrology from Ain Shams University. Professor Shams Said is an expert in the field of hemodialysis, of membrane variability. This is his interest. Also, I would like to welcome Professor Ghada Al-Qanishi, a professor of nephrology and the ex-chief of our department, Mansoura Nephrology Department. Actually, for the attendee, I would like to take their attention that if they are willing to collect the certificate of attendance, they should attend at least 70% of our activity, and they should fulfill the feedback that will appear on the link at the end of the study. Now it is time to Adam Dosagi to present the quiz. So please, Adam, go and share your slides.
Hello.
Hello.
Without further ado, I'm going to start the quiz.
Yeah, please.
Everyone have your pens and papers and things ready, okay?
Okay, Adam, please go on.
All right, question 1. What percentage of the dialysis population has atrial fibrillation? Option A is 80%, option B is 50%, option C 30%, option D 5%, and option E is 1%. Okay. Next question. The Hasbled score is the main way of establishing risk of bleeding. Which of these factors is not in the Hasbled score for bleeding risk? A, frequent falls. B, drugs or alcohol use. C, abnormal renal function. D, labile INR. E, stroke history, and F, hypertension. Okay, question 3. A 71-year-old patient with a history of atrial fibrillation on warfarin, who has a history of ESRD on HD, hypertension which is poorly controlled, and has had labile INRs in the past. The patient asks, what is his risk of a life-threatening bleed? What is their risk of bleeding per 100 patient years? A, 25, B, 20, C, 15, D, 10, or E, 5. This one's a tough one. All right, this one is a little bit backwards, so just concentrate. Which has not been proposed as a mechanism of protein energy wasting in patients with ESRD? A, hypercatabolic state. B, dietary restrictions. C, insulin resistance. D, inflammation. Or E, fluid overload. Which statement is correct? A, malnutrition prior to HD initiation has no effect on mortality. B, normal BMI, normal to high muscle mass increases mortality in HD patients. C, Low albumin levels does not correlate with increased mortality in HD patients. And D, maintaining dialysis adequacy has a survival benefit. What are the indications for dose reducing apixaban from 5 milligrams to 2.5 milligrams? A, age greater than 80. B, body weight less than 60 kilograms. C, serum creatinine greater than 1.5 milligrams. D, A, B, and C. Or E, any two from A, B, or C. Okay. Which one is true regarding dialysis adequacy measures? A, there is no universally accepted target value for KT over V. B, the target value for KT over V is less than 1.2. C, the target single pool KT over V is greater than 2.0. D, the higher the KT over V, the better. And that's the end.
Thank you very much, Adam. Very smart questions. Let's see at the end of the event what the attendee will do with the results. Now we'll move to the first lecture, and it's really will be a very interesting presentation. I would invite Professor George Davis to be the moderator for this presentation. Professor George, please. Professor George, can you hear me? Please unmute yourself.
There we go. Sorry about that. It was saying it wouldn't allow me to unmute. So this, I think, is a great topic. I want to introduce Dr. Tyler Sims, who you've already mentioned is assistant professor at the University of Kentucky. Did his, I think, his med school at University of Mississippi, internal medicine residency at UK, and nephrology fellowship at UK. And I've been reviewing his information he's going to present, and I think this is a great topic and very contemporary and continuing to evolve, that I think just based on some of those quiz questions already talked about would be a great discussion. So with no further ado, Dr. Sims.
Thank you so much, Dr. Davis, and thank you to everyone for the chance to speak today. So I was asked to talk about hypercoagulability and the use of anticoagulation for patients undergoing chronic dialysis. And you know, when I think about this, I mean, it's really a wide breadth of a topic, because there are multiple reasons and certainly a lot of risk factors that our chronic dialysis patients can end up needing anticoagulation as well. With these being some of the few. And today, in order to provide the most relevant information to the case that we're going to discuss, the caveat that I would say about this talk is that this is not going to be information that's concerning anticoagulation for all dialysis patients and all indications, but rather much more of a focus on patients with atrial fibrillation is going to be the goal of the talk today. So just to review, atrial fibrillation, it's a heart arrhythmia in which you have an alternative conduction going through the heart. Instead of getting the normal electrical pathway through the SA node down through the atria and the ventricles and getting this synchronous rhythm, you instead get these foci throughout the atria that cause these irregular electrical impulses, cause the atria to quiver and beat at a very high rate. And due to the refractory nature of the septum and the ventricles, you get this irregular rhythm where some of these electrical impulses are conducted throughout the entire system of the heart. And so thus this is how you get the irregular rhythm. And when this is the case in the quivering in the atria, you get a stagnation of blood and thus increased risk of clot forming within the heart, which then can become embolic phenomenon that could lead to a stroke. So when you look at this topic, atrial fibrillation in dialysis patients, it is a very challenging topic for the provider taking care of a dialysis patient. Because we'll kind of go through that it's not nearly as clear cut as one would want it. And in fact, back in 2016, KDIGO came together in Germany, and as part of their controversies series, they went ahead and met on this specific topic to try to dig through the weeds of how we could best serve our patients in determining whether they need anticoagulation or not if they're on dialysis. So the prevalence has been a wide range in reports, but anywhere from 15 to 40%. So this is a significant number of patients, of our dialysis patients, that end up with this heart arrhythmia. It's been found and proven that dialysis itself can actually trigger atrial fibrillation events. And then AFib increases the risk of chronic kidney disease. So an AFib patient alone is going to have a greater propensity due to multiple factors for developing chronic kidney disease. And then it also portends a poorer prognosis for our chronic kidney disease patients, as they will more rapidly progress to end-stage kidney disease. And as you can imagine, with this heart arrhythmia, it increases the risk of death for not only our dialysis patients, but also our non-dialysis patients as well. So when you assess patients in the general population, once the diagnosis of atrial fibrillation has been made, a very well validated, updated risk factor scoring system, the CHADS-VASC, is utilized often to determine for patients in the general population whether or not anticoagulation would be beneficial for that patient. And it has a series of different factors. And essentially, when you look through these conditions, what's going to happen is that over time, the patient's CHADS-VASC score is really going to only increase, because a lot of these are chronic findings or history of events that once they happen, they've happened. And if anything, the patient's just going to get older and the risk is going to get higher, which denotes that it's very important this is not a one-time assessment of the patient, and you make a decision about anticoagulation or not and move on. It's something that can certainly be revisited. And so for the male or female category, essentially men get 0 and females would get 1 point there. And what's generally agreed upon is that for men greater than or equal to 2 points and women greater than or equal to 3 points, then you should pretty seriously consider anticoagulating that patient. And that statement is for the general population. And when you look at, is this risk factor categorization, is it applicable to dialysis patients? And it has bore out that the findings are similar as far as assessing stroke risk in the end-stage kidney disease population. So with this type of therapy, where you have the potential benefit of decreased risk of stroke, but yet an increased potential for bleeding, it's not something to be taken lightly. And so really the two factors I think we're trying to balance the most for these patients is essentially the individual patient's risk of stroke versus their risk of bleeding, and which one outweighs the other as far as to determine whether or not to do this therapy. So it would be very nice if we had a tool similar to the CHADS-VASC score in which we could determine the patient's bleeding risk. And there are different risk stratification tools, but using them should be done so with caution. So the one that's going to be probably best predictor for the bleeding risk is going to be the has bled. But even the folks that devised this tool, they caution that the temptation would be to determine the annual percentage risk of stroke versus the annual percentage risk of bleed, and then go with whichever one is higher to make a decision whether to anticoagulate or not. but it shouldn't necessarily be interpreted in this way. And in fact, the Hasbleed folks that developed it, they said it's more of an identification of any possible modifiable risk factors that could be addressed to decrease that patient's bleeding risk. So unfortunately, it's not something that you could just formulaically do. You can't just put it into these two calculators to give you an answer, clear-cut answer. One of the benefits of all of these is that they have similar factors between several of them. Some of them are specifically for warfarin, which is going to be the hemorrhages and the atria, which is more focused on warfarin or vitamin K antagonist, whereas Orbit is going to look at both DOACs as well as vitamin K antagonist. But they all include some sort of adjustment for chronic kidney disease. And then it is noted that patients, they in general have an increased risk of thrombosis, but they also have an established increased risk of bleeding, whether or not they're on anticoagulation. And certainly if you put a patient on, as you would imagine, patients on dialysis who are put on anticoagulation, their risk of bleeding further increases. One thing medication-wise that may come up is with patients with AFib and they're on dialysis is kind of the debate between rate and rhythm control. It's pretty well established in the general population that if a patient's able to do rate control with such medicines such as beta blockers, that this would be preferred over rhythm control, such as amiodarone. And this bores out in the dialysis population as well. So no big changes from that standpoint as far as the treatment of the atrial fibrillation. A little bit of a sidetrack, but it's still it is an interesting paper that talks about calciphylaxis and using a direct oral anticoagulant, a DOAC, in patients that have calciphylaxis. And I think it's relevant to this talk as well because 44% of the patients had AFib as well. Now, they retrospectively looked over many years at the Mayo Clinic and found patients that had calciphylaxis and also had been treated with apixaban. And some of these patients had been on warfarin as well, but eventually all patients were put on DOACs at one point or another. And then they just followed how these patients did because what they noted is that arteriolar thrombosis is considered central to the process of calciphylaxis. So could a DOAC potentially play a role in treating these patients? And it's noted, especially if we're talking about AFib dialysis patients, warfarin itself is noted to be associated with calciphylaxis and increased vascular calcification. And low molecular weight heparin is also implicated in calcinosis and calcification. And so this was a hopeful possible therapy, and it's a very small patient population, 16 patients. As you would imagine, still a lot of the patients had a poor prognosis, but they did note that one of these 16 patients was just on a DOAC and underwent routine wound care. And that was it for the calciphylaxis, and they got complete resolution while on this regimen. And then when they looked at major bleeding events, they had one patient of the 16 that had a history of hemoptysis with pulmonary hypertension and had another episode of hemoptysis. So they discontinued the anticoagulation therapy and nothing subsequent happened, no other issues with that patient. And then they had one major bleeding event with a lower GI bleed. That patient was on warfarin at the time. And then that patient was transitioned to a DOAC and had no further major bleeding events. It was also interesting that of these 16 patients, 25% of them had normal kidney function and only 50% were on dialysis. So it's important to know that calciphylaxis can happen even in folks without kidney disease, and certainly the patients that don't have to be on dialysis for this to become an issue. And the paper itself has very impressive photos of patients with improved wound care over the course of this study. So this topic is very much in the present right now because we have papers from as recent as January 2023, just last month. Lots of good papers published in 2022 on this topic. And so this top entity here, so this is a French study that just finished last month. They shot to enroll about 50 patients. And what they're going to look at is in dialysis patients with AFib, whether they're on warfarin or not, to try to determine is anticoagulation needed or beneficial in dialysis population. And then the things that they're going to look into is a severe bleeding versus thrombosis event. And their study's been going on since 2017, just completed last month. So this next entity here was a study that was done out of Germany. And what they looked at was non-vitamin K oral anticoagulants, so like DOACs, for patients on chronic dialysis and AFib. And they were randomized to either apixaban 2.5 twice a day or warfarin. And they looked for adverse events such as major bleeding, non-major but clinically significant bleeding and death. They had 97 patients, almost a 50-50 split between the two patient groups. And they had a median follow-up of like 430 to 500 days. And what they noticed is that with the safety outcomes, there were, with these bleeding events, it was pretty much like any kind of bleeding event. Didn't necessarily have to be life-threatening. They had 45.8 events in the DOAC group, whereas they had 51% with warfarin. So pretty similar findings. And so essentially what they found was that there was no significant mortality or major bleeding difference. And so essentially what the goal of the study was is like a non-inferiority study to see if patients didn't have a whole lot more bleeding or a whole lot more strokes if they were on some of these newer agents. And that was the case as far as their data was able to support that. This third entity is a multi-center randomized controlled trial conducted in the United States, also looking at apixaban versus warfarin, 1-to-1 randomization, apixaban 5 milligrams twice daily versus warfarin. It was stopped prematurely due to lack of enrollment and issues with enrollment. But it's noted that, at least with the data that they do have, that the major bleeding events, 32% for apixaban versus 26% with vitamin K antagonist. And then the stroke risk was 3% in the apixaban group versus 3.3% in the vitamin K antagonist group. And so what they noted is that the patients with the data that they had, they certainly had higher bleeding events, and these are all bleeding events, but it did effectively have fewer stroke events if you just compare the two, like bleeding versus stroke. And so there's that. Now, this is a paper out of Australia, and I think it's a good kind of counterbalance, because sort of the more you look into this topic, there's a lot of mixed signals as far as this patient population. I think in part because we're dealing with patients that have an increased risk to clot and an increased risk to bleed, which is a difficult patient to arrive to a simple answer in. So I like their summary statement in the Australian paper. They looked at the data that was available and tried to provide recommendations. They say, unless stronger data suggesting a net clinical benefit for anticoagulation in these patients, talking about dialysis patients, becomes available, warfarin and NOACs should not be used in patients with CKD stage 5, including those on dialysis, other than on a carefully considered case-by-case basis. So I think in these type situations, we don't necessarily have like one big randomized controlled trial that can give us a clear-cut answer. You know, systemic reviews or meta-analyses, those can be helpful. Thanks to Dr. Davis for sending this one to me. So it was a systematic review in which it looked at randomized controlled trials. This group is based out of the UK. They looked from a very large time period, 1946 to 2022, interested in patients with a creatinine clearance less than 50. They pulled about 14,500 papers, narrowed it down to 53 papers. And essentially for patients, it's not quite our dialysis population that we're talking about, but they suggest in their paper that the findings are similar. But creatinine clearance 30 to 50, DOACs no difference in thrombotic events, and if anything, the papers that they pulled demonstrate a reduced risk of bleeding in that patient population, with a relative risk of 0.45 to 0.94. To shift gears a little bit from medication, there are therapies that can be done, procedures such as pulmonary vein isolation, in which you have ablation of AFib. It'd be important to know what this paper basically says is that you can't just stop anticoagulation for all patients with AFib, if this were the case. And then there's a device that we utilize here at the University of Kentucky, the Watchman device. So the vast majority of clots arise from the left atrial appendage. And there's different atrial appendage clips. The device such as the Watchman that closes over this, patients are put on generally like Plavix and aspirin until this endothelializes and then maintained on aspirin. And I think that would be something worth considering in our dialysis population as well. What information we do have, the patients on dialysis have similar outcomes to the general population. To sort of 1,000-foot view this topic, I like the KDIGO recommendation, which is basically for all patients with CKD and atrial fibrillation. It's a team-based approach. This is really a discussion between the patient's nephrologist, cardiologist, pharmacist. It's a holistic approach to the patient because we don't have clear-cut measures to determine yes, no. And I think it's a very serious assessment of how seriously we think this patient will bleed versus how seriously we think this patient will have a stroke. And if you look at the data at this point, I think it's still difficult to say which patients with AFib on dialysis we should and shouldn't anticoagulate, but it seems to be a growing amount of evidence that medications such as apixaban, in particular, a DOAC, could be utilized in this patient population. With that, these are the links throughout the talk. I want to thank everyone for the opportunity to speak today.
Thank you very much, Professor Tyler Smith, for this excellent and updated presentation. I'm just searching if we have any answers, any questions from the audience or not. Okay, till we have questions from the audience, I just want to ask about the anticoagulation-related nephropathy. Of course, not on hemodialysis patient, and those with CKD or normal population. Is there any difference between DOACs and vitamin K antagonists?
I'm sure Dr. Davis would be able to comment as well, but it seems that there's a growing body of evidence that DOACs are probably going to be more favored over warfarin. But that said, there's also the issues with cost and availability of those medications to patients. But when we consider the monitoring that's required with vitamin K antagonist, and also the risk of increased calcification associated, I think that maybe over the long term, we're reaching a turning point to where increasingly so DOACs are going to be preferred, even in our CKD population, like outside of dialysis.
I see, because I have come through some case reports of actually of anticoagulant-related nephropathy that happens also with the DOACs. You know, since a long time we have some reports and we have warfarin-induced nephropathy. But I think there is some case reports and growing evidence that DOACs are not renally wise safe 100%. And I think also the same pathogenesis of formation of intratubular clots is the same. Professor George, do you have any comments regarding this point?
Yeah, I think I heard the question. First of all, you can hear me okay?
Yeah.
Okay. Yeah, I think if we take out chronic kidney disease and dialysis. I think, what's the foundation? What's the clinical trial show is in the setting of either treatment for VTE or stroke prevention with AFib. When you look at the DOACs versus VKAs, one thing that has stuck out in those clinical trials is probably about a 40 to 50% decrease in major bleeding events, specifically the most feared bleeding of intracranial hemorrhage. And so I think that's the foundation that, has really led to them being sort of first line now by most guidelines for stroke prevention in patients with AFib, and also for acute and maintenance treatment with VTE. Now, as real world data that Dr. Sims has went through more, that seems to carry over for the most part with patients with chronic kidney disease and potentially even with hemodialysis, some of the most feared bleeding with anticoagulants. But as Dr. Sims mentioned, the presence of chronic kidney disease is also a risk factor for bleeding. And those patients were excluded if they're on dialysis from many of the clinical trials, even though in the United States, apixaban did get FDA approval without any necessary restrictions based on renal function. That was based on a very small pharmacokinetic study. You can't say they were on one hand that was in that study, but you can count them all with two hands. That sort of determine that from the pharmacokinetics. And then I think it has been confirmed. But there are, as you guys know, patients with end-stage renal disease, chronic kidney disease, usually have a lot of comorbidities that really potentially increase the risk of cardiovascular disease and or bleeding. So as Dr. Sim stated very eloquently, there's always that balance. But I think we are in a new era of anticoagulants that, to the point that I think, the director on anticoagulants are getting more and more real world data that's been supportive. And I think it's being narrowed down to apixaban, because if you look at the FDA label in the United States, I think continues to sort of be an option, especially for stroke prevention in AFib patients. And let me just mention one thing. First of all, I put in the chat a link to the American College of Cardiology Anticoag Evaluator. It's a free app you can download on your phone or even have it on your computer that you can calculate the CHADS basket. And it actually also calculates the has-bled score based on just sort of simply selecting the criteria that Dr. Sims had went through. And as you select different agents, it will sort of tell you the risk of stroke reduction and the risk of bleeding based on the has-bled score. Dr. Sims mentioned the limitations within that for true hemodialysis patients. So keep that in mind. I just wanted to share that. And then just one other quick comment. Be conscientious of drug-drug interactions. And in my opinion, with anticoagulants in 2023, probably the most significant and modifiable risk factor, which Dr. Sims mentioned, that's probably the value of has-bled, is what are some of the modifiable risk factors for bleeding? In my opinion, in 2023, one of the most impactful modifiable risk factors is overuse of aspirin in the setting of concomitant anticoagulation. So what I mean by that is, if aspirin is also on board, it's probably a 2 to 3 times increased risk of bleeding with an anticoagulant. And in that setting, I think it's always good to look at, is aspirin really indicated in that setting, when there's an anticoagulant on board as well. I'm not sure I heard the full question. If you want to repeat it, if I didn't address any of it or didn't, I'm happy to sort of refocus.
Thanks,
that.
Professor. Thank you very much, Professor George. I think we still have time to address or take 1 or 2 questions from the audience. There is a question from Amani Abdegawad. Can we use DOACs in both valvular and the non-valvular AF in hemodialysis patients? Professor Tyler. Amani is asking if we can use new oral anticoagulant in both valvular and non-valvular AF. in HD patients?
Valvular and non-valvular AFib, that's the
Yeah.
question, Noax?
Yeah, exactly.
You know, I'll ask Dr. Davis to weigh in on this too, but one thing that came up with KDIGO, because one of my inclinations would be to look at the data that's available for the general population. But it was kind of interesting. KDIGO, it's going to be biased, it's a kidney organization, but the question comes down to the cardiologist or the nephrologist, drive the ship on this. KDIGO argues it should be the nephrologist. And the reason that is that nephrologists are going to be more hesitant to take general population data and apply that to our CKD patients, whereas cardiology may be more implicated to take general population data and apply it to those patients. But I was kind of curious if we can have, it's been years since I've looked at this, Dr. Davis, but in non-CKD patients, but is there additional information for valvular versus non-valvular?
There's not large randomized controlled trials per se in valvular disease. It's still sort of, if we just simply go with labeling, it's not indicated for valvular disease, but I think it has to be sort of well defined. I think, for example, some mild aortic kind of disease, there might still be an avenue for consideration of something like apixaban, but I think that, then in that setting, I think it's sort of what Dr. Sims talked about. It's really got to become an individual case-by-case decision, and maybe bringing in, some specialties within the valvular disease to sort of really determine what's the stroke risk if we're talking about that particular. If they have a valve replacement, right now, I would say the DOACs are off the menu in regard to, but that being said, there may be certain aortic valves that they might be considered. I think a big issue is also there sometimes has to be shared decision with patient and maybe all the providers. I think Dr. Sims had a nice slide on that. When it gets into sort of these areas that it might be a possibility, because at times warfarin, just from a monitoring standpoint and potentially some of the complications that come with that, can be very challenging for a patient to be on. And so that might open the door for that kind of discussion. But I think it gets very individualized, and we don't quite have the strength of evidence to just maybe answer it. I think it gets sort of case by case. But I think there are some aortic, some mild mitral stenosis kind of disease where the directional anticoagulants might be a possibility, especially in the setting where warfarin is not a viable option.
Actually, there are many questions for this, many smart questions for this hot topic. We'll take another question. Dina Alam is asking about the use of drugs in patients on hemodialysis and the combined use of heparin as well. So her question is about, should we increase the dose of heparin if we are using drugs in patients on hemodialysis?
That is a good point. And I think we sometimes under-realize the implication of the little bit, the heparin that we use during dialysis. And I think it'd be worth considering if you do have a patient on a DOAC, maybe worth a trial to see if they really have any filter issues and truly require that heparin to get through their treatment. That would be something that I would personally do in my clinical practice.
Okay, the last question about
brings up
yes,
point is the consideration of paraprocedural management of the directional anticoagulants as well, because we do know the half-life is extended in patients with renal insufficiency, chronic kidney disease, and end-stage renal disease dialysis. So sometimes that may come into play as well. Even though that wasn't the purpose of the topic, I think sometimes it's something to be very conscientious of.
Okay, good.
I saw in the chat also someone asked about rivaroxaban, and just to say that systematic review from the UK, it essentially falls into the same category as apixaban. So it can be considered for use in dialysis patients. But edoxaban, digatroban, not recommended at all in the dialysis
To
patients.
comment on heparin and being somebody anticoagulated, the newer membranes are incredibly good, and you know, they don't clot as much as old membrane we used to have. So I usually, you know, you can even go without any heparin and see how your patient does. And then I build. If the nurse called me, I mean, he's clotting, we are changing the filter too often, then I start lowest dose that would prevent that patient from clotting. So instead of putting a set dose of, you know, unit per kilogram, start low and build to just make the dialysis going smooth. That's how I practice.
Dr. Sabri, I have a question.
Good. But Peter, what about? Yeah, I'm going.
Go ahead. I'm sorry.
I'm asking because Professor Peter opened the discussion about the clotting during dialysis. What about the coated membranes? The coated membrane, do you have any experience, or what about your comments on coating the membrane with vitamin E, with heparin, with albumin?
That's what I meant. I think we have one, and I'm amazed in our dialysis unit, in the acute dialysis unit in the hospital. It is coated, I think, not with heparin, with vitamin E, I think, or something. And it's amazing. They don't clot. It's mind-boggling that they go through the treatment, acute renal failure, bleeding in the ICU, and no heparin whatsoever, and not even frequent flushing of the membrane. So I do think they have some value.
But theoretically, in heparin-coated membranes, the clotting will increase in the extracorporeal circuits, because heparin-coated membrane will only declot the blood inside the dialyzer itself. This theoretical, isn't it?
I mean I you know, again, they're not heparin coated. I think they are vitamin E. If I'm
Vitamin E.
mistaken.
Okay.
Sorry, Professor.
I don't think we use a heparin coated one. Dr. Hisham Al-Sayed has a
Professor
comment.
Hisham.
Yes, thank you very much for sharing, and I enjoyed really the talk from Professor Taylor. So the scenario of anticoagulation during hemodialysis is completely different from the intra blood vessels anticoagulation, because there is a lot of stimulation of both platelet activation, and there is many of platelet activated factors that increase that coagulation inside the extracorporeal circuit, and on the other hand, it is exhausted and may induce even activation of the complement inside the blood. So what is the scenario and the marketing of dialysis membrane coating? I understand that because I share a lot of 20 years in development of dialysis membranes of variable permeability. What is these two categories? One is vitamin E coated, and this is from the Far East, usually from Japanese guys. And the other one has failed many times of heparin coated because they need a scaffold to be attached to the dialysis membrane. And the simplest example is the Oxalis in CRRT. In the literature, there is no difference in the heparin use or need during extracorporeal circuit between both of them. Although vitamin E naturally has been developed not for anticoagulation, but as for more of promoting the antioxidant and decrease the inflammatory reaction during extracorporeal circuit. So as you said that, there is no international guideline specifically to say what is the best anticoagulation and what is the dose. It is completely individualized according to the patient. What I am doing really, if I need the patient with heparin-free, and beside the era of COVID, the CRRT, even the heparin-coated, you need to exchange the dialyzer every 6 hours because of clotting. So almost this cannot help for anticoagulation, especially in patients with hypercoagulable state. The best way, to my opinion, in such case, is to use pre-dilutional hemodiafiltration, and it works well because the hemoconcentration inside the dialyzer is minimal, and you can achieve a good response and heparin-free. So the scenarios for anticoagulation differ from hospital to hospital and depends largely on our own experience rather than an international guidelines.
Thank you, Professor Hisham, for this brilliant comment. Regarding the heparin-coated dialyzer, we have done a pilot study in Saudi Arabia. Its name is Hemodialysis. And actually, we have a high failure rate, about 20% of the sessions, the dialyzer clotted. So there is a failure rate, as you said.
Yes, and especially that if the membrane is EN69, and so always this heparin is coated in the membrane EN69. It's an old membrane with very large amount of protein adsorption on such membrane that can activate any coagulation pathway.
Thank you very much. Very interesting discussion. We will end this part by a question from Amr. Amr, please.
No, I'm afraid we are running out of time. I will ask Tyler this. Go ahead, please.
Okay, so I would like to thank Professor Tyler Smith and Professor George Davis, and we'll move to the next part, which is the case presentation. Professor Juan Carlos, please.
Well, thank you. Hi, everyone. I'm Juan Carlos Aisnen. I'm one of the UK nephrologists. I'm here to, well, just present Amandeep Singh. So Dr. Singh, he's, of course, a fellow with us. He actually started off med school in Dayanand Medical College in India, if I pronounced that correctly. Did his residency in Youngstown, Ohio. He was a hospitalist with our hospital for some time, then hopped on over. He's going to present pretty much a case with this hypercoagulability and anticoagulants in HD, and I'll let Amandeep take it from there.
Okay. Hello, everybody.
Hello.
Are you guys able to hear me back in Egypt?
Yeah, go ahead. Yeah, we hear you very well.
Okay. So this is basically, I was hoping to present first and then Dr. Sim discuss the case, but it looked like we went first Dr. Sim. So my case, you guys already know now all the discussions. So I'm just, just going to present like as a whole some experience of whole of the patient as a whole, like, including every system and how the patient is actually, and then we can decide, what should we do with him. So I'm going to start. So,
No, man. There you go, down here.
Okay, I have this 80-year-old white Caucasian ESRD male patient was found to have tachycardia during hemodialysis session and was having trouble tolerating it. I have not seen this patient, but I have reviewed all his chart thoroughly and also had one conversation with him on the phone just to know how's the things going on with him. This is his EKG in the cardiology clinic, and he was in AFib, but of course he was having only problems tolerating dialysis. So he was in the clinic. So the cardiologist saw him. He was pretty stable in the clinic, and this is the AFib on the EKG. And he has history of history of ESRD from diabetes and high blood pressure. He's on hemodialysis for last 10 years. And I thoroughly reviewed his chart. Even I talked to his daughter. He has no history of stroke whatsoever, no history of any liver problems, no history of alcohol use, no history of smoking. He has absolutely no history of GI bleed in last 80 years, and no history of falls. He actually walks and is pretty good. He goes to dialysis, drive the bus. He goes on the bus, but he goes to the bus station on his own and go to the dialysis and come back home with his own legs. So pretty good with no falls. This is what I saw from in the chart, which I already said. He has history of diabetes, high blood pressure. We know he has ESRD from like 10 years. He has anemia of chronic disease. He has tertiary hyperparathyroidism. Maybe that thing needs to be edited a little bit, but he definitely has tertiary hyperparathyroidism with very high PTH. I'll show you in the next slides. This was his, he has a left wrist AV fistula. This is what I get from the records. Created back in 2006 and started use in 2013 and still active on the left wrist AV fistula with the pretty good flow around 1300 ml. Here you go. This is what I see in the records. He has a stenosis.
Scroll. Yeah. Just don't hit the scroll.
Okay. So he has this stenosis at the, this is radiocephalic fistula. He has a stenosis just before where they insert the needles, where you can see the aneurysm over there. This is where the access site is, but just before the access site, he has like a cephalic vein kind of narrowing and got fistulogram, and the balloon dilatation was done. This was back a couple of years ago. This is his dialysis prescription around usually blood flow rate of 500, dialysis flow rate of 800 with calcium bath of 2. And his weight is around 97.5 kilogram, pretty good muscular guy. This is his labs, which I saw with the KT over V of around 1.54. Hemoglobin pretty stable, around 10, 11. I even went before all the last 2-3 years. He never dipped his hemoglobin below 9. And his platelet count is 163. A pretty good bone marrow function over there. Phosphorus a little bit high. Calcium, PTH, as I said, look like dialysis from last 10 years. So, he has tertiary hyperparathyroidism. I did discuss with the, the physician who's taking care of this patient. They did refer him for parathyroidectomy, but the patient refused. His nutrition status is pretty good. Albumin 3.4 at age of 80 from dialysis from last 10 years. So I'll give him the credit. He's, as I said, muscular man, albumin of 3.4. This is his echo. It was done by the cardiology service. Because of his AFib, they want to see what his heart look like. Pretty good 55% EF with left atrium as a little bit dilated. Mitral valve, little bit mitral calcification. Aortic valve is good. There's no severe aortic stenosis, just mild aortic stenosis with a slight increase in the gradient. And then they also did the nuclear stress test, and there was normal myocardial perfusion. I don't see, any perfusion defect on the SPECT. And then I saw the X-ray, which it was interesting. I thought maybe I'll just show you guys. He had this aortic knuckle. He has calcification over there. So this is another CT scan, which was done for some reason. He has this aortic calcification and look like right renal calcification as well. And the kidneys are kind of atrophied. Again, just the liver looked okay to me, and his INR was fine. This is, I just want to show you the, how much calcification he has. I thought this slide is good one because I see over here, this is subclavian artery, and the vertebral artery, where it is starting from, has a lot of calcification on the right and on the left. This is another thing I want to show over here. I want to just reflect on the chronicity of this patient. 10 years dialysis. This is his parathyroid gland, which I thought it's interesting to show everybody. They're pretty wide, they're pretty big, and they're lightened up. So this guy, as I said, PTH was around 1500. He definitely has like a tertiary hyperparathyroidism. So this is what I kind of scratch my brain. How can I present this case? So I, look like, if I put all the scoring for him for his AFib, this guy need anticoagulation. This is the Chad's VAS score. His age is, this is what I did on my cell phone. Age more than 75. CH, he has, a couple of points for his age. And then 1 point for his high blood pressure. Actually, he has a history of even hypertensive urgency before, which he was admitted in the past. He does not have any stroke. Very interesting, because the way I saw so much calcification in his body, but interestingly, he never had a stroke. Even I double checked with the records and with his daughter. Vascular disease, I gave him 1 point because when I kind of searched for it, the vascular calcification on the imaging, they said it's okay to give 1 point, but we can debate on that at the end of the slide. So I gave 1 point for the vascular disease and 1 point for his diabetes history. So basically he had 5 points with his stroke risk was 7.2% per year, as whatever the study was done. Okay. And then this is has blood score, which I kind of put again on the app, which did say that he has a history of high blood pressure, which is 1 point for that. Renal disease, we know, for 1 point. And age is more than 65 for 1 point. And his 3 points on his, which makes it like 5.8% risk for the per year for the major bleeding event. So basically the cardiology, just after all of this, this is just one more slide. So the cardiology started, this patient on apixaban, 5 milligram PO twice a day. He was on aspirin, so they stopped his aspirin at that time. So this is what, basically this is the main line of the whole presentation. That they started on 5 milligram PO apixaban with the guy on dialysis from last 10 years. A lot of vascular calcification, 7% risk for stroke, and around 6% risk for major bleeding on therapeutic anticoagulation. So my question for everybody who is on Zoom meeting, so will you do the same to your patient who is 80-year-old and on dialysis for last 10 years? Thank you.
Stop sharing. Stop sharing. Stop sharing.
Yeah, it's a very interesting, difficult case again today, it seems. Yeah, I think given he's a healthy guy, instead he has extensive cardiovascular calcification, and as we know, warfarin is one of the risk factors for progression of calcifications. And even vitamin K, I mean, we know that vitamin K is in several randomized clinical trials. Some of them showed that if you give higher dose of vitamin K, you might slow down the progression of calcification. I know that there was a study called the Valkyrie study. I think they compared the DUAC with the warfarin, and they have a third arm with the DUAC and the vitamin K. So adding vitamin K to DUAC didn't decrease the cardiovascular calcification, but when they compared the square root volume of cardiovascular calcification in the aorta, in patients who received the warfarin, they did progress faster compared to the other arm with the rivaroxaban. So I think for this patient, I don't think it's a good idea to put him on warfarin. The other thing is, I wouldn't be surprised if this patient developed calciphylaxis in the near future. And my question to Tyler and to George, if this patient developed calciphylaxis, would you, and is he, if he is on oral anticoagulant, the old one, warfarin or Coumadin, would you change it to the DUAC or you keep it? And also, warfarin is not only a risk factor for calciphylaxis or calcific uremic arteriolopathy, but also is a risk factor for warfarin-induced skin necrosis. So it can induce sloughing of the skin, and sometimes it's hard to distinguish between the warfarin-induced skin necrosis and calciphylaxis. And of course, you need skin biopsy to see the calcification, that is usually typical for the calciphylaxis. So
I would say that even though it was a small study, Dr. Mohammed, but the Mayo Clinic, especially you're basically going off anecdotal evidence, but they include photos of kind of the patient's wound care. And personally, if I had a patient with new diagnosis of AFib and concern for calciphylaxis, like increased risk or calciphylaxis, I think my inclination would be to, if they were on warfarin, switch them to a DOAC, or if bleeding risk was felt to be acceptable, go ahead and put that person on a DOAC. And I think that, future studies hopefully will bore out that maybe this is even a possible treatment option for patients with calciphylaxis.
Right. And for this lesion, are you going to put him on a full dose of DUAC or you adjust it?
I think that's a tough one. I'd love if Dr. It looks like Dr. Davis is still with us because yeah, so at age, you would say 2.5 based off age alone, even within like FDA, because I think originally FDA in America, it was like for sure age and then weight if they're less than 60 kilos. And then if you look at like a lot of the European guidelines, like they always include kidney dysfunction, maybe like serum creatinine greater than 2.5. And then our American recommendations, like a lot of times the theme that comes up, what I found is that they just comment that DOACs have not really been studied in EGFR below 25. And so you work within this gray area. But yeah, I think given like he's an old man, he certainly seems to be healthy for his age, but he's going to have risk factors. I don't know that he would necessarily need the 5 milligrams twice a day to get the benefit, the decreased stroke risk. I think it would be justifiable to consider putting him on 2.5.
Very good, very good. Thank you so much. Dr. Sabri, are you with us?
I see. Thank you very much, Amanda, for this interesting case. My answer to your question, yes, I will do the same. I have a question to Amr. What about his parathyroid? I mean, this patient has a high bone turnover and he refused the parathyroidectomy. And I know that you are not with parathyroidectomy. And I think the prevalence of parathyroidectomy is not that common in the USA. What about medical therapy? Is this patient on medical therapy? First, is it a parathyroid adenoma or just a hyperplasia? And this patient is on Sina-Calcet or not?
Correct. I agree 100%. This patient hyperpara needs to be controlled because the association between calcification and the severe hyperpara is very well known. Part of decreasing his mortality and decreasing the chance of progression of calcification and the chance of developing calciphylaxis is to give him good dose of cinacalcet or maybe 80 calcitide, the IV form of calcium mimetic, especially if he has any problem with compliance.
Yeah, so he is on cinacalcet. Just sorry, maybe I miss. He is on cinacalcet.
What dose, Amandip?
30 milligram, I guess. I'm not sure about the dose, but he is on cinacalcet.
He needs, to be at least on 90, if not on 180 or something. Very good dose. We need to bring his PTH down. If we can switch, I don't know, it depends on his insurance. If we can switch to 80 calcium, the Barcibeb, the IV form of calcium mimetic, it would be better, especially if he has any compliance issue.
But don't forget about hypocalcemia with this drug, and that will in fact increase his arrhythmia risk, and also his hyperparathyroidism probably contributing to his AFib to start with. So yeah, perhaps I would be worried about his parathyroid and calcium metabolism more than whether I should or not anticoagulate this guy. That if I have to.
We are back to the CKD MVD.
Of course, it's your game. Thank you very much. Actually, very interesting case, but we are a little bit short of time. We should move to the next speaker. Professor Hisham Said, please. Professor Hisham, are you around?
Yes, I'm here.
We'll move to the next speaker. So, Professor Hisham, you are the moderator for the next speaker, please.
Yeah, okay, fine. I think Professor Gada is here to introduce Dr. Amuna.
I don't think, I cannot see Professor Gada al-Khanisha. So it's your turn.
Okay.
Go ahead.
Okay, thank you very much. It's my pleasure to join you for the first time, and I hope that to be in continuity, like exactly what we are doing in the Egyptian Society of Nephrology once weekly meeting. Today, the second part is important for understanding the dialysis, not only the dialysis adequacy by the means of 4 hours 3 times a week, but the holistic management of the patient and looking for the nutrition in hemodialysis. We understand as well that most of patients on dialysis need nutritional support and they need as well nutritional guide. We are very fearing from the development of both the frailty and sarcopenia because both of them has a worse prognosis. So nutrition in hemodialysis is one of the parts of importance, like exactly the extracorporeal blood purification. So it would be very nice to hear from Professor Dr. Amuna Tawfiq, which is Associate Professor of Internal Medicine and Nephrology from the Citadel of the Science of the Mansoura University, Egypt. So please, Dr. Amuna, go ahead, and we are waiting to hear from you.
Thank you, Dr. Hisham, for your introduction. Today, I will discuss with you a very important topic, which is nutrition in hemodialysis. First, I would like to start with my presentation with this image. I think it reflects what we see in our daily practice, a progressive deterioration of the general health, which is frequently observed among our CKD patients, especially when they are close to starting dialysis. Finally, frailty is the poor outcome. The reason beyond this phenomena have been extensively investigated, and it was explored that nutritional derangement occurring in a state of uremia is the major underlying pathogenetic rule. What about the nutritional disorder in hemodialysis patient? It is the strongest predictor of mortality and morbidity among HD patients. Different reports suggested that the prevalence of protein energy wasting varies from 18 to 75 of average 40% of our hemodialysis patients. In CKD patient stage 3 to 4 who lost greater than 5% of their body weight per year has a higher risk of this, and this risk increased by about 54% in comparison to people with no weight changes. There are many terminologies that describe this phenomenon in hemodialysis patients. However, protein energy wasting is the term that approved by many consensus in nephrology. This term refers to the multiple nutritional and catabolic alteration that occur in chronic kidney disease patients and is associated with higher mortality and morbidity and could result from decreased nutrient intake or increased catabolism. This has become more evident in later stage of CKD, especially stage 4 and 5 CKD. However, this is a cross-sectional study that evaluated the relationship between the true GFR and the anthropometric measurements. It was conducted in a higher number of patients, screening for MDRD study. The authors have found that the majority of CKD patients appears to lose edema-free weight as they approach to end-stage kidney disease, especially if the GFR approaches 30 to 35 milli per minute, with subsequent higher risk of mortality. My agenda today is to highlight the pathogenesis of protein energy wasting among hemodialysis patients, how to screen and assess patients with protein energy wasting, and what is the dietary recommendation for hemodialysis patients. This is the resources I get my slides and my information in this presentation. KIDUKI guidelines, updates 2020 updates in nutrition and CKD, International Society of Renal Nutrition and Metabolism, and the National Institute of Diabetes and Digestive and Kidney Disease. Unlike other conditions like starvation state or anorexia nervosa, in which the nutrient intake is diminished, the process in hemodialysis is more complex and multifactorial. Although inadequate food intake secondary to appetite loss was incriminated in the pathogenesis, as appetite loss was observed to be reported in 35 to 50% of our patients owing to many causes. Also, other factors are contributing, including hypermetabolism and increased energy expenditure in CKD patients, especially during dialysis session. It was reported that the resting energy expenditure increased from 12 to 20% during hemodialysis session. Chronic inflammation also play an important role and cause an increase in resting energy expenditure and oxidative stress, leading to muscle loss. The dialysis process itself have a role. The dialysis may promote wasting by removing some nutrients like amino acids, peptides, protein, glucose, and water-soluble vitamins. Also may promote protein catabolism due to bioincompatibility. What about the endocrinal state of uremia? Uremia is characterized by insulin resistance and resistance to insulin-like growth factor 1, high glucagon level, testosterone deficiency, and low thyroid hormone level, and hyperparathyroidism, which contributes more in the pathogenesis of protein energy wasting. Also, frequent blood loss during hemodialysis also contribute in this process. Metabolic acidosis also causes insulin resistance, which leads to loss of muscle mass. Associated comorbidities that commonly encountered in patients with CKD, like diabetes, cardiovascular disease, right ventricular heart failure, all contribute to the catabolic process and allow the development of protein energy wasting. At the end of the day, our patient has protein energy wasting with subsequent liability to infection, cardiovascular disease, frailty, depression. Unfortunately, these complications may also increase the extent of protein energy wasting. The second issue in my presentation is how to screen and assess nutritional status in hemodialysis patients. I have to answer two questions: how and when. According to screening, it was recommended by the guidelines or highlighted by the guidelines to consider routine nutritional screening at least biannually with intent to identify patient at risk. While if the patient started hemodialysis, a comprehensive nutritional assessment must be delivered at least within the first 90 days of starting dialysis annually or when indicated by nutrition screening. What is the tools that I can use to assess nutrition? Tools must predict outcome, must be inexpensive, easily performed and reproducible, and must be not affected by inflammation, gender, age, or systemic disease. This is a list of the traditional tools used in nutritional assessment in hemodialysis. First, I will start with the dietary assessment that can apply two types of dietary recall, 24-hour, 3-day recall, or 7-day recall, which is recommended by the guidelines is to use a 3-day recall, which conducted during both dialysis and non-dialysis treatment days. I have to assess caloric intake, protein, and other food elements. And also I have to assess factors beyond dietary intake, like medication use, knowledge, beliefs, attitudes, behavior of the patient, access to food, depression, cognitive function, to effectively plan nutritional intervention. What about weight and BMI? Unfortunately, BMI alone is not sufficient to establish the diagnosis of protein energy wasting unless it is very low, below 18 kilogram per meter square. But it has a very good predictive value. In adult patients on maintenance hemodialysis, the guidelines suggest that underweight and morbid obesity status based on BMI can be used as a predictor of higher mortality, while overweight or obesity status based on BMI can be used as a predictor of lower mortality, which highlights the phenomena of obesity paradox in hemodialysis patients. What about composite nutritional indices, like subjective global assessment? It was recommended by the guidelines to use 7-point subjective global assessment in adult patients with CKD on dialysis, and recommended as a valid tool and reliable tool for assessing nutritional status. Another alternate, which is malnutrition inflammation score, can be also used in hemodialysis patients. Anthropometric measures like mid-arm circumference, mid-arm muscle circumference, waist circumference, skin fold thickness can also be used to assess body composition, especially fat. But you have to be cautious that anthropometric measures are better to be assessed after dialysis session in non-fistula arm by the same individual. What about laboratory markers? According to the guideline shouldn't or highlighted that the lab parameters shouldn't be interpreted in isolation to assess nutritional status as they are influenced by non-nutritional factors. For example, albumin. Albumin is affected by infection, inflammation, fluid overload, inadequate dialysis, and other factors, but it also has a very good predictive value. In maintenance hemodialysis, it can be used as a predictor of hospitalization and mortality based on high level of evidence, level 1A. Serum prealbumin can also predict mortality, and values of less than 30 milligram per deciliter should be investigated for the protein energy wasting. But also its use is limited by the affection by acute and chronic inflammation. Serum cholesterol is another lab parameter that can help us to differentiate patients with protein energy wasting, especially declining serum cholesterol levels. What about NBCR? NBCR is normalized protein catabolic ratio or rate, which is a formula commonly used to assess dietary protein intake in dialysis patients as means toward determining nutritional adequacy. Through this equation, simply, I can collect this data, weight of the patient, enter dialytic hemodialysis hours, enter dialysis blood urea nitrogen rise, and I can use this formula to calculate NBCR, and it is recommended not to be less than 1 gram per kg per day. Other technical investigation that's involved in assessment of body composition in hemodialysis patients, which is bioimpedance technology. It is suggested to be used in hemodialysis patient to assess body composition, and better to be performed of a minimum 30 minutes or more after the end of hemodialysis to allow redistribution of body fluids. DEXA also is a valid tool to assess body composition. I can get from DEXA some data that help me in calculate the caloric requirement of the patient, like actual edema-free body weight, total body fat, and fat-free masses. And it is considered by the guidelines to be the gold standard for measuring body composition. Don't forget, physical examination is very important in our hemodialysis patient, including general physical appearance, oral skin health, signs of vitamin deficiency, hand grip strength, subjective visual assessment of subcutaneous tissue, and muscle mass. Now, I know that most of us say that the diagnosis of protein energy wasting in hemodialysis patient is confusing. Really, There is no single ideal gold standard measures for nutritional state. And as highlighted by the Kiduki guideline, that there is limited evidence to suggest the use of one tool over others for identifying patient at risk. So the ISRNM, International Society Renal Nutrition Metabolism, have proposed this classification or diagnostic criteria. This criteria includes 4 categories, including serum chemistry category, body mass category, muscle mass category, and dietary category. In each category, there is different variables. If the patient fulfill at least one criteria in 3 or 4 categories, then the diagnosis of protein energy wasting is established. This diagnostic criteria has unified the language between nephrologists and provided a better identification of patient at risk. Now, the last part in my talk is what is the dietary recommendation for hemodialysis patient? In other words, how can I answer a frequently asked question from our patient, what can I eat and how can I prepare my food? This is a multidisciplinary team task in which the nephrologist, nurse, pharmacist, social worker, renal specialist, dietitian, and psychotherapist are involved, but nephrologist and renal specialist dietitians carry the main task. Worsening nutrition should be identified early and managed because correcting established malnutrition is difficult. All reversible factors, including inflammation and sepsis, should be identified and corrected. Initiation of dialysis may be required, and even increasing the dialysis dose may be required. The use of biocompatible membranes and ultra-pure water can improve the nutritional state. This is all the role of nephrologists. What about dietitian? Dietitians are qualified personnel in the application of science in nutrition and metabolism. However, we have faced many challenges in providing this nutritional support for hemodialysis patient, as the availability of renal dietitian in CKD and the chronic dialysis patient is low, especially in low-income countries. About 10% of patients can have a renal dietitian. If compared to high-income countries, around 77% of patients can see a renal dietitian. Medical nutritional therapy is conducted by a registered dietitian nutritionist to optimize nutritional status and minimize the risk posed by other comorbid conditions. It must be tailored to individualize the need, nutritional status, and comorbid condition. The hemodialysis diet aims to limit build-up of waste products, especially phosphorus, potassium, and sodium, prevent metabolic complications like hyperkalemia, replace nutrient losses associated with dialysis process, as well as optimize and maintain nutritional state. What about the caloric intake? The Kiduki guideline recommends that in metabolically stable patient on dialysis and the stages CKD 1 to 5, it's allowed to take 25 to 35 kcal per kg body weight per day based on patient parameters like age, sex, physical activity, body composition, weight status, CKD stage, and concurrent illness. This is some tips for hemodialysis patient to prepare food. Generally, I have to encourage my patient to grill, boil, bake, roast, or stir-fry foods instead of deep frying. I have to encourage him to cook with non-stick cooking spray or small amount of olive oil instead of butter. Trim fat from meat and remove skin from poultry before eating. Try to limit saturated and trans fat. Read the food label and limit alcohol and smoking. Regarding protein, as recommended by Kiduki guideline, it must be 1 to 1.2 gram per kg per day, and it can be increased in patients with diabetes too. If there is a greater risk for hypo or hyperglycemia, I can increase the dietary protein intake to maintain glycemic control. Protein can be obtained from animal protein and plant protein and also protein alternatives. However, there is insufficient evidence to recommend a particular protein type, plant versus animal, in terms of effect in nutritional status, calcium, phosphorus, or even blood level profile. This is an example of protein intake for a male patient whose weight is 68 kilogram on maintenance hemodialysis. If you calculate, I think this patient will need 82 grams. He can get them from half cup of milk, 2 egg or 4 egg whites, 5 to 6 ounce or 170 grams of meat, 3 vegetables, 8 serving of grains. Please note that In 170 grams of cooked meat, only 45 grams protein is delivered to the patient. And this is one of the misconceptions that I have to teach or change in my dialysis unit. Sodium is very important in controlling blood pressure and avoid hypervolemia and burden on the cardiac load. I have to teach my patient that most of the salts come from processed and restaurant food. Fast food can allow 77% of our daily consumption. This is an example of the sodium content of a breakfast. Please note that the toast, baked bread, cornflakes contain high amount of sodium, and the recommended daily consumption is less than 2.3 grams per day. This is some tips to reduce salt intake. I have to encourage my patient to read the food label, to avoid using some condiments seasoning like ketchup and mayonnaise, to eat fresh food, naturally low sodium food, use spices, herbs instead of salt, and don't use salt substitutes because they contain high amount of potassium, and avoid salt on table. Encourage him also to read the food label, especially for the sodium content. What about fluid? Fluid are any food that contain that's liquid at room temperature. Also, most of fruits and vegetables contain high amount of food, such as melons, grapes, apples, and so on. Also, tea and coffee is considered fluid. I have to encourage not too much weight gain in between dialysis by prescribing simple tips for my patient to drink from small cups, just to take a sip to alleviate the thirst sensation. Use cool water or ice cube to alleviate the thirst sensation, and keep his mucous membrane and the skin moist as he can. What about phosphorus? Phosphorus is an enemy to the patient's bone. Phosphorus can be controlled by binder, diet, and adequate dialysis, and as recommended by the guidelines, to adjust the dietary phosphorus intake to maintain serum phosphate level in the normal range. I have to discuss with my patient the list of food that contain high phosphorus content, and I have to discuss with him the alternates. For example, here, dark colored sodas contain a higher amount of phosphorus, while light colored sodas or lime or homemade iced tea contain a lesser amount. Also, dairy food contain high amount of phosphorus, while rice milk, which is not enriched, contain low amount of phosphorus. And also, I have to teach him to avoid phosphate additives, which is an organic phosphorus that's absorbed very easily, and the phosphate binder is ineffective with many of these additives. Regarding potassium, the new guideline recommend to adjust dietary potassium intake to maintain serum phosphorus level within the normal range. I have to encourage him to avoid too much consumption of dairy products. If you notice here that the 1 cup of milk contain very high amount of potassium, approaching 400 milligram potassium, and about 222 milligram for phosphorus. This is a list of food that contain high phosphate, high potassium food, and this is low potassium food. And I have to speak with him about the alternates. For example, if he wants to take potato, he can consume green beans. He can consume orange banana. Instead of consuming orange banana, he can consume apple or peach. He can consume 2 cherry tomatoes instead of 1 regular tomatoes. White rice is better than brown rice. Rice milk is better than dairy products. This is some tips to reduce potassium in while cooking potato. For example, dicing potato into small pieces, or grate potatoes into shreds, and then allow multiple boiling process and draining. This will get rid of about 1/3 of potassium content in a potato. What about if the medical nutritional therapy failed? The guidelines suggest a minimum of 3 months trial of oral nutrition supplementation. And if failed, it's reasonable to consider a trial of enteral tube feeding. And if failed, they suggest a trial of intradialytic parenteral nutrition to improve and maintain nutritional status if nutritional requirements can't be met by existing oral or enteral intake. What about the future? The future is toward precision nutrition. Precision nutrition designed for individual patient or subgroups of patient instead of one treatment fits all models. Precision nutrition attempts to involve a complex set of patient factors like genotype, phenotype, psychodynamics, psychosocial and economic status, and past and anticipate future life experiences, among other items. Our hope is to reverse frailty in our patient, and I think if we work together, we can achieve this dream. I have finished my slides, but in 1 minute, I will present our work or our unit, Mansoura Nephrology Dialysis Unit, as a scientific work in nutrition. We have conducted a master thesis and MD thesis. One of them is interventional study conducted to study the impact of nutrition intervention on body composition and the quality of life in our hemodialysis patient, conducted by Dr. Iman Nagy. Also, we conducted a master thesis, studied the impact of protein energy wasting on longer-term mortality and morbidity. We also examined the appetite assessment score in predicting mortality and the role of malnutrition in erythropoietin resistance in chronic hemodialysis patient. These are part of our publication in the last 2 years in the field of renal nutrition. And these 4 articles is under revision by different journals in nephrology. And thank you. Thank you so much.
Thank you very much, Professor Dr. Ramona. It was very illustrative and comprehensive. You covered most of the points. I understand the shortage of time. We can add some questions and opinions. From my opinion, nutrition is a part of importance like dialysis adequacy, especially that we understand that leptin is not easily removed from dialysis techniques because it's a protein pound, although it's a small molecule, but it's a protein pound. So many of the patients with malnutrition, almost of them have inflammatory reaction, probably from catheter infection anywhere, and so CRP should be added as well in your assessment of malnutrition. Coming to what is going out from the dialysis, we understand that dialysis is blind. If you remove molecular weight 20,000, so you can remove what's good and what's bad. I always say the patient that 1 apple a day let the death away. So 1 apple a day is important for patients' nutrition, as well some of the fruits, putting in mind the potassium content. Importantly, the albumin loss during dialysis. What is the limit? It changed from many years that protein leaking membranes is bad. Nowadays, it is not so bad, but we have to put the upper limit of albumin loss depending on the physiological producing albumin from the liver. Japanese saying that during their class 4 and the class 5 dialyzer type, that the upper limit is 3 grams. With the development of more modern medium cut-off dialyzer nowadays for chronic dialysis patients, the albumin loss between 3 and 4 grams per session, still the patient anorexia improved. In our clinical research in the university, in hemodiafiltration, we have about 2 grams loss. So in the range of up to 3 grams is good. And you highlight as well, importantly, dialysis therapy is not sufficient to control hyperphosphatemia because all kinds of dialysis needs more prolonged longitudinal dialysis to control hyperphosphatemia. So we can go to opinion of expert if any of our professor need to comment for the talk before going to if there is question on the chat. All on the chat are just saying excellent talk, and they like the talk. I will like as well. I'm sorry, I lost the network for a while. So it was an excellent, but there is any questions in the chat? Professor Ala Sabri, I think you have a very good experience in nutrition during dialysis. So if you have any comment before proceeding to the next step. Professor Ala Sabri?
Go ahead, Dr. Hisham, move to the next presentation because of the sake of the time.
Okay, we move for the, I think the last one is the case scenario.
Sorry, Dr. Hisham. Sorry for all of you. I was disconnected.
Yes.
Again, thank you very much, Mona, for this very comprehensive presentation. I'm asking about the, you mentioned, of course, the importance of correction of metabolic acidosis and its bad and hazardous effect on the nutrition. My question to our partners from the UK, are you giving oral sodium bicarbonate whenever you found a patient on HD with metabolic acidosis? Are you giving oral sodium bicarbonate, or are you increasing the bicarbonate bath in the dialysis, or are you giving both? تفضل تاني يا منى.
I think, Professor Ala, yes, you said that correction of the metabolic acidosis is important for the malnutrition and bone disease as well. But if you increase the bicarbonate during dialysis, you may give the patient alkalosis during dialysis, and this is likely can do a lot of complications, including respiratory arrest. So even if you increase the bicarbonate during hemodialysis above 32 or above, you may have a rebound of hyperkalemia because potassium shift during dialysis intracellular. So I am with that to give supplementary bicarbonate in between dialysis rather than to increase the dialysate bicarbonate above 32.
Yeah,
Okay.
I can't speak for everyone, but like University of Kentucky, it's probably going to be provider specific, to be honest with you.
Yeah, it typically is. And I think there's other factors to consider is if you're going to add a further pill burden to your patient, you got to think about they're taking false binders, they're taking antihypertensives. I think if you increase the bicarb on your dialysate, I don't think it's going to, rarely have I seen an issue from that. I mean, most of the time, if they're coming in, they're 3 days a week, or if they're on home therapies, I don't see much of the issue. I have seen providers give oral bicarbonate. I think that's fine if the patient's willing to, but once again, I find that day in, day out, pills and pills and pills. All of us, if you take one pill, even that's a little difficult. So when you ask them to take 10 plus, it kind of gets, a lot of times adherence can be an issue. So I find that, I mean, you know, it does seem to be up to the provider. I find increasing your BAP, you know, a little bit over 32 is not going to be the end of it.
Okay, second comment, Mona. What about is there any guidelines or recommendation for those who have a malnutrition on dialysis to receive amino acids, precisely alpha ketoglutarate amino acids? And what is the practice in the USA?
Yeah, according to the Kuduki guideline, it was not mentioned in any of the recommendations to apply amino acids for the treatment. It can be applied for the pre-dialysis patients. It is in the recommendation to decrease the nutrient intake of protein, decrease the protein intake, as well as to give the amino acids.
What about the practice in the States? Professor Juan Carlos, I'm asking about supplementation with alpha ketoglutarate amino acids in pre-dialysis and dialysis patients. Would you recommend this?
Oh, for some amino acid supplementation in general. So we've used some protein supplementation, at least intravenously in dialysis, but those to have that done here in the United States requires a lot of pre-authorization in terms of you have to have the right patient population. For example, someone who is, well, not necessarily can be quite in flavor, has protein malnutrition to begin with, and is not able to get the supplementation or the proper nutrition at home. They tend to be patients where we give, if we even try to give oral supplementation, whether that's protein bars, work on their diet with them, and they're still struggling. A lot of times, well, not a lot of times, those few times, then we'll provide some IV nutrition from the protein standpoint. But once again, that can be very tricky. I've had some veterans through our Veterans Affairs Medical Center get rejected because they weren't, fitting the right criteria. But if you find someone, for example, who is elderly, near the end of their life, has trouble taking care of themselves when they're at home, you can then sometimes hopefully get those amino acids. And then we've done that before. So, but it does take a patient who you've gone through everything you would typically do at home through diet and whatever supplementation we'd give, like protein bars. But otherwise, we don't use it that often. I don't know if Amr or if anyone else has any experience with it.
I think it's to treat well inflammation. The commonest cause of malnutrition in patients on dialysis is dialysis impurities, infection, inflammation, and so you can bridge the gap between controlling all the inflammatory reactions by supplementary proteins orally or IV amino acids. If the patient's liver is okay and if it's not in volume overload status always, but still you need to control the infection and to control the dialysis adequacy properly by more prolonged dialysis and more permeable dialysis membrane, probably as well hemodiafiltration. So it is a bridging you can do by supplementation of proteins, but it isn't always the lifestyle to go through.
Also, to add that, I reviewed the literature, Doc. I was reading up to date. It mentioned that they have some studies that looked for giving amino acids to patients with mainly hypoalbuminemia, but I guess that we are not prescribing routinely to the patients. And it mentioned that it needs further studies ongoing.
I see. Good. We still have time for question for Mona. Rola Osman is asking you, Mona, what about keto diet in dialysis patient? Any response?
Keto diet.
Yeah.
It's recommended to take diets which is contain a high biological value of protein content, but I think it's recommended to decrease the amount of, as I mentioned, excess fats to help healthier blood vessels of the patients. So I have no experience with keto diets, but I think the recommendations is against using this in hemodialysis patients.
I think a keto diet can decrease the progression of polycystic kidney disease. There are many research about this, about keto diet and ED, BKD. But for hemodialysis patient, personally, I don't have any experience. Amr or any of our colleagues have any experience about using keto diet in dialysis patients?
It's not recommended keto diet in general, not in dialysis patients in always, because you are free, especially if in countries are not using glucose-containing dialysate. It will be very problematic, and the patient go to normoglycemic ketosis or hypoglycemic ketosis. So it is not recommended. We have to do a balanced diet, protein content, vitamins, fruits, less in potassium, and generally away from phosphorus. So protein content in meats, chickens, and others is good. Besides that, you have to complete the diet by carbohydrates for energy.
I see. There is another question from Agbo Antoni. Is asking about nutrition in CKD in sub-Saharan Africa. Any practical tips? I think it will be difficult for Mona. I think to
What
answer
is the
this
question again?
Nutrition in CKD in sub-Saharan Africa. Any practical tips?
It depends on the national availability of foods and the kind of food. I understand the sub-Saharan because I am chair of the hemodialysis chapter of the African. So the problem in sub-Saharan is beyond the nutrition. It is the dialysis. There is no facility for dialysis. Only 10 to 15% in patients who developed end-stage kidney disease can find dialysis. And 50% who started dialysis go away for dialysis for financial reasons. So I think the answer is first to develop well-programmed, funded, should be from the WHO or ISN to control the mortality from end-stage kidney disease in sub-Saharan. But there is no specific diet for sub-Saharan.
Good. Very interesting discussion, but I'm afraid we are about 20 minutes far beyond the time. So if we can move, please, to the next case presentation, Professor Juan Carlos, please.
Sure. So, well, I'm here to present with Atabak Parsa, one of our fellows who, went to medical school in Iran. He did his residency in the University of Maryland, and I'll let him, present away.
Hello, guys. This is Atabak Parsa. Nice to meet you all, you guys from Egypt and US. So I don't know how much time do we left. So I have like a brief case presentation and some short, slides on that. I won't go through all of them because Dr. Mona already discussed about the malnutrition in hemodialysis patients. So we have a kind of like a challenging case of malnutrition in hemodialysis. This lady is an 84-year-old lady. Past medical history was significant for ESRD. She was on a Monday, Wednesday, Friday dialysis through her graft for the past 10 years. CAD, HFpEF, P and DVT on Eliquis, chronic anemia, diabetes, and history of dementia. That this dementia was challenging. That we go further through that. She lives in a nursing home facility here in Lexington, Kentucky for a while with a healthcare professional actually help her conduct daily activities of her living. She's a retired case manager for the past 4 years and reports that most of her friends and families passed away and she doesn't have much to live for now. So as we mentioned, past medical history, mainly her ESRD was secondary to her hypertension, nephrosclerosis, as well as uncontrolled hypertension, given she had multiple hospital admissions in the past due to uncontrolled hypertension, as well as uncontrolled diabetes, with diabetes, retinopathy, and nephropathy, and the rest of the past medical that we discussed. Past surgical history was significant for cataract surgery and left toes amputation secondary to diabetes complications. Family history was significant for breast cancer in her sister, diabetes and hypertension in both her parents. Social history, she never had any smoking history, alcohol or illicit drug use. and allergies, she didn't have any known drug allergies. Home meds, as you can see, it was amlodipine, Eliquis, atorvastatin, seizure medications, Correct, clonidine, famotidine, Keppra, levothyroxine, losartan, and vitamin D supplies. So we tried to contact the patient. However, due to the dementia, I was not able to physically see the patient. But I called the nursing home facility as well as I talked to the dietitian that was working with her. She mentioned that she's on a renal diet as well as on her vitamins as well as protein supplements. But she was very reluctant and was refusing all her supplements and sometimes even her meds. As per hemodialysis unit records, however, she was compliant with her hemodialysis sessions as well as she was sitting for the full 3.5-hour dialysis sessions, except those sessions that she missed because of the ED and hospital visits. Outpatient dialysis was Monday, Wednesday, Friday. Dialysis unit is a Fresenius in our city. Outpatient nephrologist is Dr. Casiliano. She's one of our attending physicians. And the residual function was none. Estimated dry weight was around 74 to 75 kilos, and access, as we mentioned, was a left AV graft. So as we can see here, the estimated dry weight and pre and post weight, also the pre-blood pressure as well as the post-blood pressure was within acceptable range. And as you can see here, the average blood flow rate was within acceptable range 400, which average dialysis flow 1.5 to 2 times, with the average dialysis duration is 3.5 hour. But we know that it needs to be close to 4 hours, as literature mentioned. And it needs to be close to 4 hours. But for sake of time and other stuff, we usually do like 3.5 hours, close to 4 hours. And so before going to the other labs, I would like to discuss some slides regarding dialysis adequacy measures. As we know that there is no university accepted target value for KT over V, and we use KT over V as a marker of minimal dialysis adequacy. This suggests that KT over V over 1.2, and in order to achieve that minimal KT over V, we need to have a target of single pool of 1.4. And even if the next thing is that even if the minimum KT over V is achieved with shorter times, we suggest a minimum dialysis session of at least 4 hours rather than a shorter time, because shorter sessions increase risk of morbidity as well as mortality. Other thing is a URR, which is a urea reduction ratio, which is closely related to the KT over V, and it's a fractional reduction of the urea during a single dialysis. It is calculated with 1 minus post-dialysis BUN divided by pre-dialysis BUN, and is useful as an epidemiologic tool. Its efficacy is in individual patients is more limited because of a relative broad range of KT over V that may be seen in a given URR. And it is measured every 12 to 14 treatment, which is almost once a month, and may vary treatment to treatment. So if there is like a single URR in a one single treatment, we shouldn't judge based on that, and we have to have like a range of and mean of actually URR. It should be around more than 65% to have like a good number. And this I took it from UpToDate. It shows that if we increase the dialysis dose, it really improves the survival with the apparent maximum benefit of a KT over V around 1.3. As we said, average would be 1.2 with a single pool of 1.4. So here you said like in between 1.3 with a URR of 70%. Next one is a PCR, which is a protein catabolic rate. As we know, is also called the protein equivalent of the nitrogen appearance, stands for PNA, that can be used to assess dietary protein intake in hemodialysis patients who are in a steady state. The point is that the PCR is determined by measuring the intra-dialytic appearance of the urea in the body fluids plus any urea loss in the urine in patient who has residual kidney function. So we need to keep that in mind. And the PCR is usually expressed as gram per kg, body weight per day, which is a parameter that is also called NPCR that we'll see in the above patient. Also, a simple calculation of NPCR requires only the pre and post blood urea nitrogen and the calculated KT/V, which is obtained during a single dialysis session. It also mentioned that the NPCR varies directly with the KT/V, which is a marker of dialysis adequacy. As dialysis adequacy increases, it leads to a protein intake, and thus the NPCR goes up. However, the NPCR is independently associated with the morbidity and mortality of hemodialysis patients who are adequately dialyzed as expressed by KT/V over 1.2. The optimal target of NPCR is over 1.4 gram per kg per day. However, this target is very difficult to achieve. Therefore, we kind of like lower it down to 1.2 per day. And as we mentioned, it should be measured monthly, along with the other measure of nutritional adequacy. Intensive nutritional counseling by a renal dietitian should be done monthly to help maintain a minimum PCR of 1.2 to ensure that the patient is getting enough nutrition. And our goal is to give oral protein-based supplements that should be beneficial among patients who are malnourished. So based on those stuff, we can see here the patient had a BUN and a post-BUN numbers, and the URI pretty good. And as you mentioned, URI needs to be over 70, and the patient had this goal. Also, here we can see that the patient had some mild hypokalemia. That's why the dialysis prescription was switched from 2K back to 3K back to adjust those numbers. Also, the next slide, we can see that the patient also has like an anemia. However, because of the normal iron level as well as the transverse saturation, we're thinking that the patient has some sort of anemia of chronic disease, that the patient was receiving Mansoura during dialysis sessions. The next slide shows the one that we were talking about, the single pool KT/V, as well as the equilibrated one. And we can see the numbers are always within our goal over 1.4, and these numbers are always over 1.2. So we were like reaching our goal. However, the PCR and the NPCR, usually we said that it needs to be over 1.2, but the patient did not reach their goals. It was always below 1. That's why we actually tried to optimize her nutrition status based on giving her the nutritions and supplements, but unfortunately the patient was not really agreed to those. I really was very reluctant to those supplements, and it was really very difficult to manage those malnutrition in her. And as we can see, the albumin was always on the lower side, 3.2, and I think as Adam decided to put in one of the questions, this is one of the single most important factors that shows if the albumin goes below 4, it really increases the rate of morbidity and mortality in the patients of hemodialysis. And as we mentioned, the hemodialysis prescription was 3.5 hours. Our goal is close to 4 hours to decrease the morbidity mortality. The dialysis was 3K bath, 2.5 calcium, 140 sodium, 34 bicarb, and we tried to remove 1 to 2 liters of fluid as tolerates. And as we mentioned, the patient was on Mansoura and vitamin D supplies based on the treatment medications. So the next slides are really talk about the pathogenesis. I think Dr. Mona already went through that. So I don't know how much time did we left. Doctor, could you tell me how much time do I left? So should I go through those?
Finish the case.
You still can have 2-3 minutes.
Okay, if I have 2-3 minutes, then I think Dr. Mona went through all these slides. I'm just skipping this one. Just want to make some bold stuff regarding the albumin that we discussed. If the albumin level goes down, you can see the odds ratio of the death really goes really high, especially if the numbers go below 4. Also, again, this shows that the hypoalbuminemia is associated with increased risk of morbidity and mortality, mainly at the albumin level of below 4. And the next slides I just want to skip. These are the protein energy wasting that we mentioned. There are different proposed mechanism: decrease intake, also hypercatabolic state that are in our dialysis patients, inflammations, and other comorbidities plays a huge role in these cases. Insulin resistance, especially in diabetic patients, are very important in this PE, wasting. Metabolic acidosis, as Dr. Aysenina mentioned, we really try to optimize her metabolic acidosis by helping them. Possibly bicarb is feasible in these cases, and the dialysis procedure, because we said that the dialysis procedure is kind of like a catabolic, state that may cause, to protein synthesis and loss of amino acid in dialysis. Also, the dietary restriction is very important, and also medication, especially fast binders that can, impair the, nutrition absorption. I have more slides to show, but I think, as I mentioned, Dr. Mona went through that. Just the last one, I just want to talk. There are some experimental methods as well as recombinant human growth hormones, androgen anabolic steroids, anti-inflammatory drugs, and zinc. Also, I want to add amino acid to these slides as well. However, none of them really showed, none of them is FDA approved, and they are still in the experimental phase of, things. Thank you very much, guys.
Thank you very much, Atabak, for this very interesting case. Sorry, because sometimes I have a bad connection. Did you survey hair or look for other causes for hair malnutrition? Such as inflammation and malignancy.
Unfortunately, Doc, I was not able to, talk to her. She's alone, as I mentioned. She's in a nursing home facility. But I I reviewed the chart, as well as I talked to the dietitian, as well as Dr. Castellano, my attending physician that was taking care of the patient. There was negative for any cancer in the past in her, basically.
I see. I think from presentation from Mona, we should stress that there is no one variable that can assess either dialysis adequacy or nutrition. It's a collection of many variables, as you said, and as Mona mentioned before. Do we have any comments or questions from my colleagues or from the audience? I don't think we have anything from the audience. Any comments or questions from the my colleagues? Okay, I'm afraid again we are a little bit sorry. Any comments? Okay, we are a little bit, as I said before, we are exceeding our time, so we will proceed to the answers of the quiz. Adam, please, can you present the answers for the quiz you have mentioned in the start of our meeting?
Yeah.
Those are just the questions.
These are the questions.
Okay.
So go to the download.
Downloads, go to downloads.
Right there.
With answers, yeah.
Adam, can you share your screen, please?
Yeah. Just give me 1 second, sorry.
Okay. Okay, back to the ketogenic. Are you ready? Back to the ketogenic diet. I think Rola Osman is insisting that there is some reports about ketogenic diet and uremia. So Rola, if you can please share it with me on the private chat. Okay, Adam, here you can go.
Okay, so the first question is, what percentage of dialysis population has atrial fibrillation? The answer is 30%. So the general population, if you take all comers, the general population atrial fibrillation in America anyway, the incidence is about 0.5%. Once you get over the age of 60, the population prevalence is about 4%. However, the prevalence in HD patients is between 15 and 40%, depending on the studies that you look at. So the best answer out of these is about 30%, which is about what we see. Okay. The next question is the Hasbled score is the main way of establishing risk of bleeding. which of these factors is not in the Hasbled score? And the answer was frequent falls. So this is the Hasbled score. Luckily, it all the letters correspond to a criteria. So if you just remember Hasbled, it should be enough to remember what's in it. Hypertension, abnormal liver or renal function, stroke, bleeding, labile INR, elderly greater than 65, drugs or alcohol. And so frequent falls is not in the calculation for your bleeding risk. Okay, so 71-year-old patient with atrial fibrillation on warfarin who has a history of ESRD on HD, hypertension poorly controlled, and labile INRs in the past. So this was a hard question because you had to work out the Hasbled score. The Hasbled score, which I'll show you, is 4. Patient has hypertension, abnormal renal function, labile INR, and is greater than the age of 65. This Hasbled score correlates to a bleeding risk per 100 patient years. So a score of 4 is about 8.7, which is, I think the closest number here is 10. So what that means is in every corrected 100 patient years, there will be 10 episodes of a life-threatening bleed. So that can be then worked out as a percentage likelihood per annum. And if you use the online calculators for the Hasbled score, usually it will give you the answer. Once it's given you the score, it will give you the answer underneath and tell you what the risk of bleed is. Okay, so which of these is not a proposed mechanism of protein energy wasting in patients? After these excellent lectures now, hopefully you all know that the answer is fluid overload. There are patient-related factors, intercurrent illness factors, hemodialysis factors, but fluid overload doesn't cause protein energy wasting. Okay? All right, so which statement is correct? This one was a good question as well, and it's maintaining dialysis adequacy. Hello, can you hear me?
Yeah, go on.
Okay. So malnutrition prior to HD has an effect on mortality. We've clearly seen that. Normal BMI and a normal high muscle mass doesn't increase mortality, it reduces mortality. And albumin less than 4 is correlated with an increased mortality. So those are key takeaways from that nutrition talk, I think. Okay, what are the indications for dose reducing apixaban from 5 milligrams to 2.5 milligrams? So I'm glad that we saw this because this came up even in our discussion. So essentially, this number for serum creatinine, there are differences between the different societies, but just know that this is an indicator for renal dysfunction. So age greater than 80, body weight less than 60, or a serum creatinine that's elevated, and it's 2 out of 3 of these is an indication to decrease from 5 milligrams to 2.5 milligrams. So for example, if you had a dialysis patient under the age of 80 who had a normal body weight, you would say that ideally they would have just one of the criteria out of the 3, and you would potentially put them on a full dose of apixaban. Okay? All right. And these are the recommendations. So it's any 2 from over the age of 80, weight less than 60, and serum creatinine greater than 1.5. Okay, so which one is true regarding dialysis adequacy measures? So the answer is there's no universally accepted target value for KT/V. And the reason is actually, it was just mentioned just before this. KT/V is just one measure of dialysis adequacy. To figure out whether someone has optimal dialysis, you need to know about their anemia management, blood pressure control, fluid status, nutritional status, metabolic bone disease management, etc. So KT/V is just one measure out of all of these global outcomes for dialysis, which is why there's no accepted universal target. And that's it.
Okay, good. Thanks, Adam, for the answers of the quiz. Okay, I think we have come to the end of this meeting, but before I will say goodbye, I just want to let you know that we will select those who have a highest score during this meeting from the attendee and from the next two meetings, who will be our valuable invited guest to our 13th Mansoura Nephrology and Dialysis Unit that will be held this September 2023. And we'll announce, of course, those who will get the prize next meeting. Also, I would like to take your attention that our next meeting will be in a couple of months from now, and we'll announce for the exact time when we fixed this time. I would like at the end of this meeting to thank all who contribute to the success of this meeting, the attendee, of course, to my colleague, my deep thanks to my colleague, Professor Amr Husseini, Dr. Ala Abdel Nasser, Professor Nagi Said Ahmed, Dr. Mark Nagy, Professor Lohani, and Dr. Yara Mohammed. Also to the moderator, Dr. Ahmedoya, Professor Ashraf Abdel Basit, and Dr. Katran. I would like to express my deep thanks also to the speakers of today's meeting, Dr. Adam Dosaji, Professor Dr. Tyler Sams, Dr. Amandeep Singh, Professor Mona Tawfiq, and Dr. Atabak Parsa. Also to the co-moderators, our great moderators, Professor Hisham Sayed, Professor Juan Carlos, and Professor George Davis, and of course, Professor Peter Sawaya. I would like to thank all of you and to see you after 2 months from now. Thank you very much and goodbye.
Thank you.